Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest in North Carolina. Brian, how are you?
Hey, Pete. Excited for this episode. This will be fantastic.
Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, so today we have an episode on a new and exciting topic, which is new arthroscopic alternatives for the patient with recurrent glenohumeral instability and glenoid bone loss. And to discuss, I've invited two international superstars who've developed their own procedures to address this challenging clinical situation. So first, from Halifax, Nova Scotia, we have Dr. Ivan Wong. Ivan, welcome to the podcast.
Hey, thanks for having me again.
And then next, from Barcelona, Spain, we have Dr. Abdulilah. Hachem, welcome to the podcast.
Hey, good afternoon. Good afternoon from Barcelona. I'm exciting to be here. Thank you very much for the invitation.
Oh, we're very excited to have you. So I wanted to start with the rationale. So we have decades of evidence to support the efficiency of the open Latarjet for glenoid bone loss, right? And there's still many people performing it this way. We know that it works well. So I wanted to start with you, Hachem. Why not just continue with the Latarjet? So why are you innovating in this space?
Look, this is a many reasons. All of us now, Latarjet present a high complication rates, mainly for the beginners, for the surgeons in the beginning. If you look at the rate of how many Latarjet you can do for a week, if you have bone loss, it's almost in majority of surgeons, the selection with this technique, it's not high, it's low. So they are doing 10 cases, less than 10 cases per year. With the less than 10 cases per year, it's lead to high complication rate. So, and if you look at the complications, mainly after having done good technique, the direction of the screw, so metal screw is the main issue about Latarjet. And in the best hand also. So this is what my thought was, why we should avoid these screws in the beginning and go to the arthroscopic way to avoid this Latarjet as a non-anatomic technique for me. We go through the subscap, we change the anatomy. I don't speak about the efficiency of the Latarjet and good result, but this is in my mind, I try to avoid any harm the patients. The subscap, we know the subscap, what's happened to the subscap after cutting the subscap, and the atrophy and sometimes degeneration in these procedures. If you have controlled that, and we know also how it's difficult to control, to follow this patient with MRI, with the screws, with the metal in between for MRI or and in CT scan also. So this is my mind. I was worried about all these times. So this is what I started years ago, doing bone block, fitting by bioscrew in the beginning, and then change it to buttons, and then now lastly with cerclages.
Okay, Ivan, I know you've also thought a lot about this, about why not just do the open Latarjet. But I know that you're a very talented arthroscopist, and I'm sure that's pushed you. Tell us why we should move on from just an open Latarjet.
Yeah, well, I think we always need to look back because you're right. The open Latarjet is the gold standard. So no matter what we do, we got to compare back to the Latarjet. And problems with me is the main deficits with this, right? So Abdul has already mentioned screws can be a problem. The subscap split is definitely a problem because doing a subscap split, I know people say we don't violate it, but it really limits your view. It's a very small hole in there. No matter what you do, the bigger the hole you get to be able to see more, the more you damage that subscap. And some people do, partial takedown and osteotomy, and those unhealing of subscap is a big problem. And then when you can actually do this, damaging that nerve, that plexus. It's right beside here. And we got JP Warner's detail on that, showing that even if you don't think you damage it, at least a quarter of the time, it feels the retraction we put on it. So it's not benign. And even the best surgeons in the world have documented lacerations of those nerves, iatrogenically. And that just really changes your outlook on life on these young patients who are looking for shoulder instability surgery. And then when you look at it longer term, what bothers me is Hovelius's work showing long-term outcomes of lateral J are good, but we are getting arthritis. Whether the arthritis happened before or after, it really doesn't make a difference. These patients are getting surgery when they're young. So chances are when they hit the age of 80, or even before that, they're going to need a second surgery for arthritis, whether it was before the instability surgery or after. Again, not making any comment on that. But if they need a second surgery after a lateral J, when the anatomy is completely changed, when your plexus is completely scarred down to that area, is very nerve-wracking. So those are the real reasons why open lateral J, though it's successful, likely has a better option that we need to still be looking for.
Ivan, I think your point is great. That if you have to do another surgery, the alteration of the anatomy with the lateral J it could make that surgery very much more challenging. I wanted to ask you though, just to follow up on Hovelius's data, because I said the same thing you in one of our conferences a while ago, and the challenge I think that we have with that is that if you look closely at Hovelius's data, while many of them have arthritis on X-rays, there were very few that required shoulder replacements. So I guess my question to you would be, what has been your experience with this? I mean, you've been treating shoulder instability for a long time. How frequently is it, do you think, it actually requires an arthroplasty later on?
So I think this is going to be measured in many years, in decades. Okay, so all his work, again, he has out to 25 years, and I have not been practicing for 25 years. I hope to be practicing out 25 years, but I can already see some of my predecessors' work. So when I inherited my practice, I see many of the patients that were previously treated with lateral J, previously treated with putty plaques, with thermoplasty, and we're seeing them coming back now with shoulder pain. It's not end-stage arthritis yet, but it is definitely moderate arthritis, and they are headed towards that way. We do know if they live long enough, and these people are young, they're still in their 40s, maybe 50s, they will require some kind of treatment if all the other conservative measures stop working. And I think the measurement of just requiring shoulder arthroplasty as your end goal is not the right measure, because at the time of that study, they have not had the arthroplasty yet. But patients are having pain. So this is what we need to look for. We need to look forward to know that these patients who are still having pain likely will need some other treatments for. And we want to make sure that we give them the most options and the safest options out there.
So, Ivan, I think those are incredible words of wisdom. I think it's important for us to acknowledge the work of our pioneering surgeons in this field. And when you talk about arthroscopic options, it's important to acknowledge the contributions of the French and European school, particularly Laurent Lafosse. Ivan, I know you've done many arthroscopic lateral J's. Maybe can you tell us what's a significant advancement of an arthroscopic bone block versus a open procedure?
Yeah, so there's no question Laurent Lafosse is a pioneer in this. I spent time to go try to learn from him and his colleagues, especially Emilio Calvo in Spain. And technology is always important, and I think that's what this brings, because arthroscopic lateral J has really allowed us to take that procedure and visualize it much better, to understand the nuances of how we put those screws in, of how we harvest the coracoid, of where we want to actually do our split. And arthroscopically, we can see better. We can see from multiple different planes that we could never do before from open surgery, and we can address other lesions inside a shoulder. So that advancement allowed us to see or to think about it in another light, to be able to say that, look, these complex surgeries completely outside of the shoulder, outside of the cuff region, in nerve areas that we were worried from before is definitely possible. So by doing this, we've actually opened the door to all these other techniques to be able to address a shoulder instability with a completely different framework. So I think, again, arthroscopic lateral, huge leap forward in multiple ways of doing this, with Laurent Lafosse and Pascal Boileau really leading the forefront of this, and now being able to allow us to look at it at a different level with different approaches to complete shoulder problems arthroscopically.
Now, Hachem, just to pivot on that, we've often debated about the role of the sling effect, right? We talked about the triple effect with coracoid transfer, and you've done some novel, innovating work in free bone blocks. Do you think the conjoint or the sling effect is real, and where might that contribute?
It's a good question. As mentioned by Ivan, that till now, lateral is a gold standard for the instabilities. These are our references. So, but because if you look at the lateral J, when in some, from Laurent Lafosse, he burned the capsule. After that, starting with Pascal, he reattached the capsule. But no one from them, can do lateral J plus capsule application. It's not the same. Because if you do a bone block by introducing the graft through the rotator intervals, and you respect all the time the capsule. For me, the capsule is very, very important, the capsule to proprioception, and not for the proprioception, also by overlapping, by chafing the capsule from south to north, from lateral to medial, reattaching the capsule. This is we can overlap a la carte the inferior enlarged and stretched capsule. So this is what we can do with arthroscopically. I learned from my mentor, John Armengol. He learned from Luis Bigliani in Colombia 20 years ago how we can do open capsule chief. I started doing open capsule chief. I overlap from inferior to superior. I still do it in special patient with very, very high sulcus inferiorly, because we cannot applicate capsule in the humeral side with the same quantity as in the glenoid side. So, but if we restore the anatomy by restoring the glenoid tract or the glenoid side, plus reattaching, plus retention, this capsule, enlarged capsule, I still believe this is a sling effect, this is anatomic sling effect that could be compared to lateral J, to the sling effect with the conjoint tendon,
I love that thought, that because I know both of you are bringing the graft through the interval, so then we don't disrupt the subscap. We're no longer getting the sling effect from the conjoint and the subscap. But I know both of you are also repairing the soft tissues, and maybe that's our sling effect. So would you say then that one of the main reasons why you pivoted to going through the interval is not just not violating the subscap, but also maybe because then you could do this capsular shift that we've all done as part of our soft tissue procedures? Or was that a kind of a secondary benefit? Hachem, as you shifted towards your procedure, how did your thought process evolve there?
Yeah, definitely. Because in the beginning, I always detach the capsule, detach from 1 o'clock. This is crucial to do this technique. I detach at 1 o'clock and goes down until 6, 7 o'clock at the end of the glenoid rim inferiorly. So I put one suture traction through the upper part of the subscap percutaneously. This tips comes from Pascal Boileau by PDS suture to put it for the anterior glenoid capsule and the ligaments. So I keep it far through the skin with a mosquito, and then I have a big punch anterior inferior, and then I can work there. And then at the end, I check always my patient. If patient have hyperlax, shoulder hyperlaxity with ER at the side more than 90 degree and hyperabduction more than 120, sorry. So I believe this patient with this enlarged capsule, we can shift it. I mean, you bring the 6 o'clock to 4 o'clock at the end of the procedures by finishing the glenoid restoration of the glenoid. So then we detach again this point and reattach the capsule without soft anchor to put it at the same level or at shifting a la carte. This is my thought and my anatomic reconstruction of the tendon of the structure, damaged structures.
Now, Ivan, would you say that your capsular shift is also somewhat guided by the patient's preoperative range of motion or your perception of their hyperlaxity, or are you? I know you've told me before that you're aiming for kind of a certain distance of shift, maybe less so than like around the clock.
Yeah, so I would agree with you that it really is based on the patient. So somebody who is more lax, I will want to shift it more. Somebody who is not, and it's in a more of acute tear, I will not worry about shifting it. The number that I talk about, how much I shift the capsule, mainly because I put that traction stitch at 3 o'clock, and then I can reattach it at any position on the glenoid, is so I can measure and report how much of a shift I do. So somebody who is more lax, I will be shifting it more than 2 centimeters. Somebody who is not lax, and this is an acute non-soft tissue injury, but more bony injury, I try to shift almost nothing at all.
Those are incredible thoughts, because it's probably a topic that's discussed very little as you talk about bone blocks as well as humeral-based management. So I think that's great. Ivan, to kind of set the stage for your current graft of choice, you've certainly migrated, it seems like, towards the distal tibial allograft. What do you like specifically about this graft? And then maybe as a follow-on question, for those naysayers that say, hey, you're taking an osteoarticular graft and then you're covering it up with capsule, maybe offer your rationale for that and lead in on that discussion. Absolutely.
So again, I think we all work towards our strengths, and my strength is not a basic scientist. I'm an arthroscopist. I'm a clinician, right? So I'm good at miniaturizing an approach and trying to find some. I'm also an educator, so I really enjoy teaching and trying to find a good way to teach something. So my graft of choice has gone towards the distal tibia because people like Matt Preventure has taken it upon themselves to show how good this type of bone graft is, how good the mechanical factors are for that subcortical bone, how strong it is, how good the cartilage kind of blends in, the thickness of it to a native glenoid cartilage, how the curvature fits. So all those things I did not have to do. And now I'm really focused on the technical parts. And then I can follow the remodeling portion. So because that was already done, the cartilage that is on that distal tibial allograft is almost the exact thickness of a native glenoid cartilage. So when I place this into the shoulder arthroscopically, all I have to do is line up the cartilage on the native glenoid and line up the cartilage on the distal tibia. And if I have a switching stick in there, it doesn't require my eyes to line it up. I can physically palpate it to line it up. And when I line it up that way, a post-op CT almost always looks perfectly flush. I've tried to do the exact same technique when using iliac crest because we also do this when we don't have distal tibia involved. And I'll tell you, I try to line up the cortical bone with the cortical bone on the iliac crest, and a post-op CT does not look perfectly flush. I'm always off by just under a millimeter, whether it's proud or whether it's recessed. I don't think it's clinically relevant, but it is definitely a lot more difficult to do a perfect orientation of that. What's actually even more interesting is the distal tibia has a nice flat shelf to it. So not only do I want to line this up perfectly flush to the edge, I want to recreate the nice concavity of the native glenoid. And Philip Marauder has actually shown that concavity of the glenoid, especially the anterior rim, that last 1 millimeter of bone, is probably the most important part of the concavity of the glenoid to be able to keep the shoulder in socket. And by using the distal tibia, we can actually angulate this almost being accurate to every degree to recreate about a 2 to 4 millimeter depth of that glenoid concavity. So again, distal tibia, I really do think works really well because other people have done the basic science to it. I've really just focused on the miniaturization of this to be able to technically do it through the interval. Again, with screws, as well as hopefully showing a good way to teach other people how to do this safely.
Yeah, Ivan, and I think you're underrepresenting your contributions to our society. So thank you so much for your pioneering work. Hachem, by the same token, you have certainly innovated in the iliac crest, and in a current era where a lot of people are moving away because of fear of donor site morbidity. Maybe you could share some of what you think are the merits of the iliac crest, what you like about this graft, what represent maybe some potential limitations, and how you're using it currently.
Absolutely. After having done more than 100 cases, I can tell you how was my experience. I started using autograft iliac crest, IGBJ. With autograft, it doesn't matter. You can heal, you can have a great union rate, but you still have resorption. And then I started using allograft because in Barcelona we have a good tissue bank. But what happened from the allograft, what I was thinking, it's we cannot control the donor, because sometimes the donors comes from the old women with osteopenia, osteoporosis, and with morbidities. So at the end, we started to select the donor iliac crest bone. But we sent to AGSM our result, our 23 cases, mixing autograft and allograft. From the autograft, this was done perfectly without any full resorption. But 3 cases came from allograft, suffered full resorption. But in general, the resorption is outside the bed-fit circle because this is unloaded zone. So I believe in iliac crest, but it's true. Many patients, almost 20%, have discomfort, little bit discomfort from the iliac donor side, and they are worried about it, but not pain, not as a big disturbance. So, but encouraging from Matt Provencher. Provencher was in our shoulder course in Barcelona in last November. He encouraged me to do distal tibia as Ivan mentioned. I did now 10 cases in the last 6 months. I was very, very surprised. It's a very, very strong bone because this is load-bearing bone. It's not as iliac crest. I mean, in fact, it's much stronger than the autograft iliac crest because if we compare both, you can see the cancellous bone with big holes from the patient. But if you compare with the distal tibia, it's amazing. It's like a wood block of bone. So and in these cases also, if you put your hole, your drill bit a little bit key-centric to respect the center of the graft, to adapt the graft to the patient, it doesn't matter because it's never you can block this DTA. This is I was surprised. So now I don't have experience more than 8 months. So I follow this patient pre and post op CT scan. This is my only issue now. It's what happened at 1 year with resorption to compare distal tibia to allo iliac crest graft. This is don't have experience because I know Ivan published about distal tibia with buttons is more resorption than screw. I'm a little bit worried about it because I know this publication comes from Ivan, but in fact we did a biomechanical study comparing cerclages with buttons, and we know from the spring effect, we know is not the same. From the spring effect, at the end, the compression between the bone block and glenoid, or the coracoid process with the glenoid, is strongest at the end of the cyclic loading, comparing the cerclages with buttons than the screw, because this is circular compression and not linear compression. Because this is my experience now. I started to do a detailed distal tibia. I'm very happy, but it's a short experience. I hope in the future can tell you about what is the resorption rate comparing the allograft.
Hachem, that was just a beautiful description of, I think, the center of what I think is somewhat of a little bit of a mystery or an enigma right now. So you've published that. Marcus Scheibel has published the same thing. Very high resorption rates with allograft iliac crest. And I think we all know that autograft crest is great graft, but there are patients that complain about hip pain. Maybe not forever, but at least temporarily. So I want to ask you this, Ivan, because I don't quite understand this. Why do we see resorption with allograft iliac crest and we don't see resorption with allograft distal tibia? Is it what Hachem said, that it's load-bearing bone and it's better bone? Is it that we're not following the patients as long? Why is there this real, I think, huge difference in the literature between those two grafts, both of which being allografts, both using the same settings in resorption rates?
Yeah, so I don't know what you're referring to for Marcus Scheibel. I don't know how he was fixing it. Was he fixing it with screws?
It was bioscrew. Bioscrew.
Yeah.
Bioscrew. So it's not regular screw, different type of screw.
No, it's very soft screw, and I use it in the beginning. This is like neutralization, not compression, not high compression system.
Correct. So I think that gives you your answer. So we can't compare apples to oranges in anything we do, right? That's the whole problem with all this. And when you get a lot of people doing things different ways, that is the problem. Is we can't compare one to the other. And if you change something, that's not the same anymore. So you got to be very careful with what you do. I'll tell you the reasons why I focused on that distal tibia is because, just like Hachem mentioned, it's the bone is so strong. It's a great analogy. I want to talk about it. It's more like wood compared to a sponge, right? So you want something that's that strong. Now, one of the good examples of this is Ettore has started with open ladder J and then moved for autograft iliac crest, and he didn't have very good success rate with that using buttons. And then he's moved from that to allograft, and that also had trouble. And now he used equine bone. And the reason why we change all these things around is if you switch it to something that's denser and something that's so non-immunogenic, then it's not going to remodel as fast. And if it doesn't remodel as fast, then it won't change. So if you get a post-op CT at the same time point, it's not going to get the same type of resorption or remodeling, whatever you want to call it. So why would distal tibia work well? Well, distal tibia is very strong bone. Allograft distal tibia is very strong bone. So it takes a while to remodel. If you take femoral head, other things that people have used, they remodel very quickly because they're soft. And if you don't use a very good compression technique, you're not going to get the same type of remodeling rate. So the way I do it is I compress the heck out of the allograft so that I'm trying to get primary type of bone remodeling in there, where the osteons can actually grow into it and then change the calcium right away. And instead of forming a callus-like tissue or enchondral bone formation. So again, the concept has to be the same if you want to compare apples to apples. And that's why I think right now, as we move into this age of what is the best graft, what is the best fixation, we have to be very careful at following these things and very careful to analyze them as we go ahead before adopting another way to do something.
Yeah, that's a great response, Ivan. And there's really so many different avenues we can go down from here, but I'd love to take on this topic full force, and that's really the concept of fixation. We all know the downsides of screw-based fixation. We've certainly tried to modify that with making solid screws, with adding washers to avoid graft fracture. But I think as we look towards moving towards a metal-less implant, Hachem, talk to us about potentially where we need to go next to make this more reproducible, because a lot of us are concerned about the potential for continued micromotion. Is there potentially for this type of fixation to cheese wire through the graft? Maybe talk us through your initial journey with going to a non-screw based construct.
I was worried about metal. So in the beginning, I used bioscrew, but what I found it is bioscrew as Ivan mentioned, we didn't have a full compression with this bioscrew. Bioscrews, I put sometime 2 or sometime 3. This is not a high compression. This is at the beginning. I feel a more resorption remodeling, as you mentioned, we can say. So then I started to use 2 buttons, but this is at the end using big button anteriorly and button posteriorly. I can't control my graft by doing CT scan. I can't control how I couldn't measure how is my graft resorption. And then when I saw these tapes for cerclages for fracture, with this old guide from the company, I started to use it because this is a circular one, and I could control everything. I could control every area from my graft because I divide the graft in 2 columns, 6 areas, and by measuring every single area, and I could analyze what's happened with this with graft. So and after having done more than 100 tests in the lab, we know also from the Pascal publication about how many newtons we need to reach this union rate between the graft and the glenoid. We know almost 100 Newton, 120 Newton. We don't need much more, because if you put more tensions, at the end you lose union rate, because the circulation, the low blood pressure can't pass through the graft and the glenoid. So at the end you cannot reach the union rate. So if you put too much pressure, at the end this area, surface area in between both graft and glenoid, it suffered a lot and it cannot pass these small vessels. So now we know from our biomechanical testing, we only need 100, 120, 140 newtons. That means if you use a tensioner with a pound, it's like 30 pounds. So now with this tools, we know you will reach a good union rate, almost 100%, more than 95%. So this is my first thought about this kind of new fixations using tapes. The second thing to do, we should put 2 tapes, not 1 or 2 systems, and interconnected them. Because if you put individual systems, at the end you will struggle with this with the sliding sutures, with the slacks in between. But with interconnecting tapes and the sutures, you slide down and you reach high strong fixation, high strong compression in between the surface.
Yeah, excellent. Obviously very data-driven in that discussion. Similarly, Ivan, you've done a great job of honestly reporting your outcomes. I'm kind of curious to talk about where you see a suture button construct, or something that Hachem has mentioned in his studies. Where do you see that playing into your current algorithm and method of fixation?
Yeah. So I think I go back to the start, right? So when we started this podcast, it was like, why are we switching from Latarjet? So we want to find something that really doesn't hurt our next surgery, or makes it least hurtful. And I've done my fair share of button or suspensory type of fixation. So having a button on one side or the other side, and then compressing it together with a tensioning device. And I have not had the same success rate as I have had with the screw fixation. We're having 30-some% failures, essentially complete resorption of those. But when I say 30 to 40% complete resorption, I'll tell you that's 60% complete healing, right? So of those other patients that healed and remodeled, their glenoids actually look completely normal. So it's fantastic. It's just the rate of failure was too high for the ones that I don't like. But I've had the experience now to try to revise those. And the revision of something that you put a button in with a very thick suture, so a number 5 type of suture that's also fixated from the back, is not the easiest revision. Those suture holes that you drill through are actually quite large when you look at them. They're just as large, if not larger, than the drill holes that we use for screws. And especially when you put these suture buttons in, there is some kind of bungee cord effect in there. So those holes actually get bigger. So you're losing more bone in there. And when you try to remove them, you actually can't remove all the suture. You can try to cut it as best you can. You'll have to go through a bunch of shavers and graspers and cutters. And you do go through quite a few of these because these are really strong sutures. They don't want to go anywhere. So if you're trying to do this for infection, that might be problematic because you can't get it out from the front. You'll have to get it out from the back, of which then now takes the nerve into play. So there are always consequences to everything we do. So we just have to be aware of what consequences we want to go for. I've also had experience of removing screws, and screws, again, is not easy as well. They're a metal piece going around. But the good news about metal is they tend not to be reactive. It is a piece that you move out, and I've had pliers and clamps and be able to get it out and twist it out, and even in a mangled fashion, but they don't tend to break after or while you're trying to get it out the same way as suture comes that kind of out piecemeal.
Okay, so that's a beautiful description of, I think, the ups and downs of screws versus buttons. So we're getting close to the end here. What I was hoping to get from both of you is, what to you is the ideal current solution? So for both of you, like what is the pinnacle of what you do? Like, where do you think, what is it? And just go through for me, hopefully, what's the approach? What's the graft? What's the fixation? And then maybe a little bit of thought to, what do you think this looks like in 5 years? What do you think the future looks like? So I'm hoping Ivan, maybe you go first. Tell us, what are you doing right now, real briefly, and then where do you think we're going to go in the future?
Yeah, so right now I'm doing a screw fixation with washer through a Halifax portal, so a far medial portal, done from an inside-out technique to make it completely safe. It doesn't become a suicide portal or anything like that, but because we go using anatomy, it is a safe approach. And using distal tibial allograft, custom fit to whatever size defect, using 3D modeling to help us pre-plan all these. And then doing a soft tissue fixation by doing an inferior to superior capsular shift and being able to measure the amount of shift, also doing a remplissage at the same time if so they need it. And so that's my current approach. When I look back, it's actually what I was probably doing just before I switched over to buttons and then switched back to this way. And it's been very good, and we're out. We're going to be hopeful that we can start showing our 10-year results in the next few years, because our first patients have just passed the 10-year mark and they've been doing very well. What will we look at like in 5 years? Well, I think this has generated enough discussion that I do think bone block technique is going to be here to stay, right? I think we are going to be developing a safer way, more reproducible way to address all the intra-articular problems, doing it arthroscopically this way. I do believe that the fixation will change. Screws with washer is, again, that's the oldest technology we have, but we do know how to get out of trouble with these, meaning how we remove them and whatnot. Sutures have their own difficulties, but they are not, they have not been developed to the point that we know how to remove them completely yet. I think that is going to be the next frontier, is how we can make sutures strong enough, or another type of material like that strong enough to be able to withstand the forces of a shoulder to get remodeling the way we want, that we've seen with screws.
Okay, and then Hachem, again, you've talked to us about, your transition over time through grafts. It sounds like you've dabbled a little bit in distal tibia. Obviously we know you've had some experience with that crest. Tell us right now, what's the ideal for you in terms of approach, graft choice, fixation, and then again, where do you think you'll go in the future with this?
Great. I think now we should do it more reproducible and safe. If you take a look at the last publication from Dinar about what in state you are doing about for bone block, for bone instability defect, and more than 2/3 of North American surgeons, the indication is latarjet. But the 95%, they are doing it by open fashion. So by open fashion also, we now have complications. So but these surgeons, is not, I mean, they are doing also arthroscopic advanced surgeries, but they prefer to do latarjet by open. So our goal, I think our goal is in the future is to do it by safe way, reproducible, by distal tibia fresh frozen. I don't use fresh because it's very expensive. I advise fresh frozen. It doesn't matter for me now. And by introducing from the rotator interval to respect the anatomy, and then I would I would bend to say in the future we are going to avoid metal. This is my way, because now we demonstrate that by suture cerclages tapes we can reach the same compression as not close to the screws, but we don't need high compression in the beginning. I mean, we demonstrate that with 125 is enough. So this is a good way to see it. It's reproducible because it's easy. In advanced surgeons, we don't need 5 portal, low portal through the subscap, through the axilla. We don't need that. We don't need, but we can achieve the capsule without going to distal, to inferior. And then I guess in the future is going to, this is my hope, to avoid metal, to every single surgeon can reproduce this technique, and a la carte by chiefing the capsule. And we need also we should debate what's happened with heel sac, because heel sac is a bipolar lesion. I mean, the majority of this patient have bipolar, so we don't forget the backside of the humeral head. And still, if we restore the glenoid shape, we still have, in some cases with a huge heel sac, we still have engaging and off-track lesion. So in these cases, we should add also in our algorithm bone block plus remplissage. But in my mind, if you have a huge heel sac, you never should feel all the heel sac. But if you feel in this huge heel sac, you will lose external rotation, you will lose range of motion. So if you add remplissage to bone block, whatever you want to do, put it, but feeling only the half or one more than 2/3. I mean, we don't need to feel all the heel sac to avoid this complication in the post-op range of motion. This is my algorithm in today, and my advice and my hope for the future.
Well, I want to thank both of you for coming on. This has been amazing. I mean, you both have such an incredible wealth of experience in this area that I think is an area that we're increasingly focused upon as our techniques advance. And your experience shared with the listeners, I mean, listeners are going to love listening to you talk about screws versus tapes versus buttons versus which graft do you use, and why the open latarjet was great, but maybe we can do better. So I really appreciate both of your times, especially coming on with us during a Saturday so that we could accommodate the time change. So again, this has been amazing. Thank you so much.
Thanks for having us. It was great.
Thank you very much for the invitation. I'm really enjoyed for having me here, and to meet. I hope we can meet in person with Ivan, with Brian, and with Peter again.
I, for one, would love to soak up more pearls of wisdom on this. I think you all are doing a great job to, share your data on long-term outcomes and what's the secondary rate of osteoarthritis, and do we improve the natural history of post-instability arthropathy. There's so many other areas we can discuss here, but I just really want to thank you for taking the time. Unfortunately, that's about all the time we have for this podcast. I just want to thank you as our guests, and for our shoulder and elbow listeners out there, don't forget to subscribe. And for Peter Chalmers, I'm Brian Waterman. We'll see you next episode.